Yeah, you can let people in, please.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CARN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Hello, everyone. Can we hear me?
Yes, we can hear you, Dr. Loretta.
Excellent. Hello, everybody. Good morning, wherever you are listening from on the globe. It's today, Saturday, the 10th of August, and it's time to listen, learn, and gather knowledge for our optimal health and general well-being. We want to say well done to the Caribbean African Health Network and the Targeted Health Hour team. Well done for all you're doing, making people's lives better. Today, we have somebody who is going to tell us something that we all need to hear, and she's an expert in that field. We have Dr. I'll likely call her Miss Marwa Jama, because we call our surgeons either Mr. or Miss in the United Kingdom. It's nice to have you on this program today. She's somebody who is of Somalian heritage, a registrar general surgery, Yorkshire training region, and she's a very senior trainee at ST5. She's currently doing research which changes this world. Research will tell us the what, the why, and why we are having certain trends. And she's doing research in a place very, very passionate to a lot of us in the community, and that's in ethnic diversity, ethnic divergence as well, and inclusivity. So she's looking at why surgeons of ethnic minority do not have the same sort of attainment trajectory as homegrown or based doctors here in the UK. We are looking at bowel cancer, all you need to know. So without much ado, I'm going to be bringing Miss Marwa Jama to tell us what's bowel cancer, what's the screening about, what makes the Caribbean African Health Network or community different in assessing care, screening, management. What should we be doing? I met Dr. Loretta Oboroko. I'm a consultant obstetrician and gynecologist myself, and I'm very happy to be here this morning. Miss Marwa Jama, the floor is yours, please.
Thank you very much for the warm welcome and introduction. It's much appreciated. I will attempt to share my screen and then we can hopefully get started this morning. And before I do that, I'd like to thank the audience profoundly for coming here today, and hopefully we can be of value for you. After the presentation, we will open the floor to discussions and questions, and I would be very keen to hear what you have to say. So let me see if I can share my screen.
Yes. Everyone is welcome to use the chat to send in questions as they occur to them during the talk.
Can people see my presentation?
I'm not seeing it yet.
Not just yet, Dr. Mo.
Okay. And now?
Yes.
Yes, we can see it now. Thank you, Dr. Mo.
Lovely. So today I'll be talking to you about bowel cancer, and we have some aims for this morning. So the aims for this morning are to talk about bowel cancer, what is it, but also what the risk factors are, and especially the modifiable risk factors, what symptoms people get and how people are diagnosed, along with the screening program, which I will try to spend some time on because I think that's very important for our community. And then I will talk a bit about what happens to people who are diagnosed with bowel cancer and how the treatment schemes usually look like, and the things after diagnosis, and how, again, we can optimize things a bit more for our own communities. So a big disclaimer for today is this is a talk to educate you about generic things, generic symptoms, how to navigate the healthcare system, etc., how to participate in your screening, and how to recognize alarm symptoms. Obviously, if you yourself are concerned about yourself or a family member or a loved one, I would strongly recommend you to see your GP or any other specialist that you've got access to in your own country's context. When I'm talking today, I'm talking mostly about the UK system when I'm talking about systems, but obviously symptoms, etc., are quite similar across the globe. So, bowel cancer. Sorry, I think there's something wrong with my screen here. Can't seem to, oh, there it is. So when we're talking about bowel cancer, obviously the gastrointestinal tract and bowel get used a bit in a confusing manner. So when we talk about the gastrointestinal tract, you have the stomach, and after the stomach comes everything that we call bowel. So both the small bowel and the large bowel. The small bowel is a direct continuation of the stomach and is several meters long. And is usually split up in two parts. The small bowel then ends up in the large bowel, and the large bowel is about 1.5 meters to 2 meters long, and ends in the rectum and then the anus. So it is the last part of the gastrointestinal tract. And when we talk about bowel cancer, even though you can get cancers of the small bowel, we mostly are talking about colorectal cancer. So today I'll be discussing colorectal cancer. So colorectal cancer is one of the more common cancers in the UK. It is the 4th most common cancer in the UK, and it is because of the distribution of other cancers, it is slightly more, it's the 3rd most common one in the Black community. When you look at the current population's lifetime risk, because of how often it occurs in the UK, about 1 in 17, 1 in 8 to 1 in 20 people will get it during their lifetime, which means that if you've got a room of 20 people, one of us will end up having a colorectal cancer once in their life. So, colorectal cancer does have some risk factors that have been extensively studied, and I will try to go to them today. And I will especially pay attention to things that are more modifiable than others. The biggest risk factor is age. cancer in general, and specifically colorectal cancer, is a disease of age, a disease of the elderly, which is obviously not really a modifiable risk factor. All of us obviously want and hope to get old. But as you can see, colorectal cancer incidence goes up during your lifetime in almost a linear line from 40 onwards. So it is severely associated with age. Another modifiable risk factor is diet. So in diet, one of the things that has been linked is red meat or processed meats. The theory behind this is not fully clear. Some theories are that the way that meat is cooked and grilled releases some chemicals that then damage the repair systems of our DNA, which we'll go into too much depth if we talk about this, but it basically then puts you at risk of not being able to repair your DNA, and that's how tumors start. And in another theories are that it truly has to do with the way that our body digests the meat. But in general, it is now a widely theorized fact that too much red meat or processed meats in your diet can cause or put you at risk for colorectal cancer, and that they attribute to possibly up to 10% of the colorectal cancers. So the general recommendation is to limit red meat and processed meats in a healthy diet to about twice a week. The other one that gets recognition and that's attributed to quite a few colorectal cancers is a low fiber diet. And a low fiber diet, again, the theory as to why exactly it causes cancers is not known. The more accepted theory is that too little fiber means that you have a slow transit of your stool through the bowel, and that obviously our diet in general and all the carcinogens in our food then are exposed to the bowel wall too long, and that therefore you get a higher risk. So as part of a healthy diet, it's always good, not just for colorectal cancer, but for lots of other conditions, to have a healthy, balanced diet that includes fiber. And when we talk about fiber, good fiber sources are things like lentils, peas, chickpeas, pulses, grains, rice, oats, and then dark fruits and vegetables such as all the berries, broccoli, prunes. Other risk factors that are accepted, because there's a lot of fables out there and a lot of myths, but the ones that are accepted in the medical world are things like obesity, smoking, alcohol, radiation. And by radiation, we do not mean radiation by cell phones or the background radiation you get nowadays from a bit of flying, etc. No, it is for people who've had radiation in very high doses and settings. So most of the time, these are people who've had radiation therapy for a previous cancer. Diabetes is still up for discussion, if that's a risk factor or not, and it's a very difficult one to investigate. But as now, it's not acknowledged as a full risk factor. Colorectal cancer is partly, but absolutely not fully, familiar linked, and that can be by different things. It can be by diseases that predispose you to a cancer of the bowel. So you must have heard of conditions such as ulcerative colitis or Crohn's, which is an inflammatory bowel disease where the body's own immune system causes inflammation of the gastrointestinal tract, and this can then predispose you later on, or actually relatively young, to a colorectal cancer. And there are also genetic familiar syndromes that cause risks to usually several types of cancers in one go, or that cause risks to developing lots of polyps in the bowel that can then become a malignant tumor later in life. So these are the things that put you at risk, but I also want to discuss what symptoms then to recognize if you are that unfortunate to then develop a colorectal cancer, what are the symptoms? And this is where a bit of difficulty occurs, because the symptoms of colorectal cancer, and in honesty, a lot of the gastrointestinal cancers, are symptoms that a lot of people get for more innocent reasons. And it is a very difficult thing to recognize when it is not innocent. So most patients that end up having a colorectal cancer will have their main symptoms being either a bit of abdominal pains, bloating, cramping, kind of vague symptoms, and bleeding. That is what the majority of symptomatic patients will have had as their main symptom. People can also develop weight loss. Weight loss is obviously an alarming symptom. So weight loss that's unintentional and unexplainable for other reasons. Anemia, so that means having low blood levels, low HB levels. And anemia is very often with the right-sided cancer, so the start of the colon, while very left-sided cancers or rectal cancers can give false urgency, the feeling that you need to go to the toilet without really needing to, or that you can feel a bit full at your bottom end, but it being a false alarm, or feeling like you can't fully empty all the time. But as I'm reading this, you can also imagine that these symptoms belong to a lot of what we call benign, innocent diseases, and it is difficult to distinguish when it's what. So, one of the things that has truly revolutionized colorectal cancer care and that has prevented a lot of incurable cases is screening. And I think this is the one thing where we can take control, and that's participating in screening. All the data suggests, unfortunately, that ethnic minorities, and that includes the Black community, so the Afro-Caribbean community, does not pick up screening in the same rate that our white counterparts do. And that is not just because we have a younger population, our elderly people do not pick it up in the same rate. So, what is the colorectal cancer screening? So the colorectal cancer screening goes through your GP, but every 60 to 73-year-old gets what we call a FIT test, so stool test sent to them through the post. If you're registered with the UK GP, you should be receiving this when between this age of 60 and 73-year-old every 2 years. And since a year ago, they've been trying to expand it to 54. So in certain regions, they're rolling it out to send it earlier and earlier and earlier. This is a very easy and simple test to do at home. I apologize for this unappetizing topic in the morning, but I think it's important we get over the shame of discussing these things for the sake of our health. So it means doing a normal stool as you normally would in a clean surface in the toilet. And then this they supply you with a little scoop. You scoop out a little bit of stool from the top of the feces, and you put it back in the sample kit, and you send the sample kit back. What this does, it tests for invisible blood. Because if you've got a bigger polyp or a bigger tumor, they very often have a little bit of a bleed, but that blood gets digested within your stool, it gets absorbed within your stool. And if it's not large amounts, it's not something that you necessarily would have noticed. But this picks up the blood that we wouldn't see with our bare eye. About 2% of people who participate in the screening test will have a test that is positive enough for them to go for further testing. And the good thing is the further testing then very often catches most of the time it catches nothing. It can be negative. So it does have the side effect of going for a colonoscopy and then being reassured. But if it catches something, it will very often catch things like bigger polyps and small and tumors, hopefully at a lower stage, meaning that you get caught at a stage where you are still very treatable, and also sometimes treatable in a manner that is less invasive than if it had proceeded to a bigger tumor. So, along with the screening, the other thing, that's how people get diagnosed. But along with the screening, it is important to see your doctor about the aforementioned symptoms. So even though they are vague, the recommendations that we could make is for the older age group. So people are, and for the older age group at this point, we would say over middle-aged, over 40, things that should at least you should see your doctor for are things like your altered bowel pattern for 3 weeks. So if you're someone who normally runs a bit constipated, goes every 2 to 3 days, but suddenly you're in your 60s and suddenly you are going twice a day, or the other way around, you normally go every day and now suddenly you're struggling with constipation and there is no other change. It's not as if you've turned your diet around or traveled abroad, etc. Then these are reasons to see your GP. Rectal bleeding. So rectal bleeding, in most of the cases, it is not a cancer. Most of the cases, it will be other things, but it is a very important symptom to see your doctor with. So rectal bleeding, so that can be either fresh blood on your stools, fresh blood within your stools, or fresh blood losing it without stool, as well as your stool color going a bit darker and you having the feeling that there's something bloody or darker in there. Weight loss without an explanation is an alarming symptom, and that's an alarming symptom not just for colorectal cancer, but any malignancy in general, and it's something to see your GP with. And the other thing it causes is anemia, and anemia symptoms, which occur slightly late, are things like fatigue, having a very low exercise tolerance, getting short of breath on things that you normally could do, like walking the staircase, etc. And people go a bit pale, which obviously, again, is a very difficult thing to see with our skin color, but we can still see it in the white of our eyelids. So, if you see your doctor with symptoms, what are things that you can then expect? Obviously, the GP should be asking you questions and you should be having discussions regarding the length of your symptoms, the type of symptoms you're having. They should be evaluating what kind of pain you're getting, what pattern of bleeding you're getting, etc., going through your family history, all those kind of things. You can then expect to have an examination of your tummy. It's just with a bare hand examining your abdomen. And very often, especially if you're presenting with things like false urgency, feeling something below or having bleeding, then you have to expect an examination of the anal canal, which means that they put a gloved finger inside the bottom end to have a feel and see and assess if you've got any hemorrhoids, but also if you've got any palpable tumors or masses already at the bottom side. Most of the time they will do some blood tests and other tests depending on your symptoms, and send those off. And the combination of these things along with your age can trigger a referral to the hospital. So the hospital referral can be something called a 2-week wait, which is also called the cancer pathway. Obviously, depending on the severity of symptoms and things you've already told them, they sometimes have to send you straight to A&E. And sometimes your symptoms are less worrying, but still warrant a referral, and then you'll go for an elective normal waiting time referral to the hospital. If you, for example, present with rectal bleeding and you are 62 and you present with rectal bleeding, that triggers an automatic referral. If you then get put on this 2-week wait pathway, you will see in your notifications and in your letters, etc., and the communications that it also gets called the cancer pathway. This does not mean that you have a cancer or that the GP has seen something that they immediately have diagnosed you as a cancer. It means that a concern is big enough to worry about a cancer, and the 2-week pathway is a pathway that just is so streamlined that it can get you a diagnosis in a much more timely fashion than an elective wait would be. So even though it sounds scary, it doesn't necessarily mean that they've diagnosed you with a cancer. It is just a pathway to facilitate a cancer diagnosis. And it is indeed that they are worried that this is the one thing that needs to be either included or excluded. So when you go for the 2-week pathway, most of the diagnosing when you go to a lower gastrointestinal tract 2-week wait clinic will be with CT scans and endoscopies, depending on your symptoms. We know that from research that ethnic minorities, including the Black population, on average attends their GP on more occasions to trigger the pathway that eventually gets them diagnosed. So we don't know what causes this exactly. We can all have our theories. And we know that there is disparities, unfortunately, in the way that people get perceived and treated. So I think it is important for you to also know what you're entitled to. So, for example, one of the things that really should trigger an automatic concern is if you've got rectal bleeding and you're over 50, even if you have hemorrhoids and they feel hemorrhoids, it does not necessarily mean it is hemorrhoids. It needs to be checked what is above there as well and make sure you're not bleeding from something more sinister above the piles, the hemorrhoids cushions that you get from the anus. For altered bowel pattern, persistent abdominal pain, for people over 60 or in some centers now mostly over 50, that's also an automatic trigger. So you obviously in a communicative way, these are scenarios where you can then advocate for yourselves and your loved ones. There are guidelines out there. There are resources which I will share with you that tell you a bit about alarm symptoms, when to see your doctor, and what you can expect and be entitled to. It helps to know what symptoms are so you can vocalize and verbalize things better and verbalize your concerns better, but also know what kind of care you should be receiving. So I think very importantly in this section is do your screening. That is where we can make the biggest difference here. When you have symptoms, see your doctor. You can voice your concerns and voice it when you are alarmed. Some of us, and I'm speaking from a personal background, is we have a culture that tells us to be grateful or to not be confrontational with things. But if you have concerns and you've seen your GP for a reason, make sure that you feel listened to, heard to, and that you've been able to voice your concerns. When you go to hospital, you are entitled to a translator that you don't have to bring. It doesn't have to be your child or your loved one that breaks news to you. The hospital has to provide you with either a translator via phone or via phone or in person. And this is an entitlement that you have, and that can really take a burden away from your loved ones having to translate, which can also be quite difficult for second and third generation children who might not be equipped to describe things as much as in the medical vocabulary. The 2-week pathway also can sometimes bring a bit of surprises. They are rolling out because there is so much demand and so much waiting time. They're rolling things out like straight to test, which back in the day meant your GP would send you to the specialist to be seen. You would then get seen, talked to, and then sent for your tests. But that appeared to cause an unnecessarily delay, especially because most people's tests would then end up being normal or normalish. So now lots of young, fit and well people who don't have much issues and with relatively straightforward symptoms will go straight to their test. But that means the first time you're going to hospital, you might not be seeing the doctor, you might be going straight for your colonoscopy. And the colonoscopy, etc., also requires some preparing on your diet and drinking your laxatives, etc. So make sure to stay on top of your communications, your letters, and be prepared for the different pathways that you can follow. And like I said, the cancer pathway does not mean that you necessarily get diagnosed with a cancer at the end of it. So, diagnosis of colorectal cancer is, in most cases, actually almost exclusively done by CT scanning and endoscopy. So depending on which one you've had first, they either find something suspicious on the CT scan or they find something suspicious on the endoscopy and take biopsies from this. And then a complete diagnosis would be by having the biopsies of whatever has been found on the endoscopy, along with a CT scan of not just your tummy, but also your chest, to do something called staging. So the biopsy will tell you if it is a cancer, and then the CT scans will tell you what kind of stage it is. For a rectal cancer, so that means the end of the colon, most of the times you will also have an MRI scan to see how the tumor locally is growing. And this allows staging, and staging is very important for prognosis and treatment planning and what can and can't be done. So cancer, and you must have heard this very often, presents itself at different stages. So for every cancer, we divide it up to stage 1 to stage 4. And for colorectal cancer, it means that stage 1 and stage 2 are local tumors, and they get differentiated between stage 1 and stage 2 depending on the growth they've done on that area. The stage 3 is then that they've got localized invasion of the tissues, or they've got a bit of lymph nodes within that area. And stage 4 is when they have metastasized, so when they have spread to distant organs, which in the case of colorectal cancer is the liver and the lung first, but then it can spread anywhere else. The survival and prognosis of these stages is vastly different. A stage 1 colorectal cancer has a 90% or more chance of being alive after 5 years after diagnosis, while at a stage 4, that drops to 10%. And stage 2 and 3 are 80 and 60% respectively, meaning it is important to be diagnosed early. And this is again why we are having these chats today. So once the diagnosis is made, which can take a few weeks because the biopsies needs to be looked at under the microscope, you need to go for all your different scans. Then you need to get discussed in a multidisciplinary meeting to talk about you and what your options are. And then your specialist will sit down with you and talk to you about the diagnosis, the treatment options, and take you through the next steps. So obviously the conversation will include the news. It will include the different treatment options there are available, or the path that they are proposing to you. It depends on what kind of conversation you want to have, but you can ask at this stage what kind of staging it is and what you would like to know. These are discussions that can be had, and within either this conversation or next one, the consenting process for any operations also starts. Some people have to be investigated further rather than immediately starting treatment, if there is some diagnostic uncertainty, or if there is, or sometimes it can be that you have to be assessed, for example, from an anesthetic point of view, to see if you are fit enough to go for an operation. At this point, and I think this is again a bit of a disparity between communities, and it might explain why the research tells us that ethnic minorities have a much more negative experience in being diagnosed and going through treatment, is that getting to this stage warrants allows you to get a lot of different types of support and networks. One of them being a cancer nurse specialist. So in the UK, we have a system that there are cancer nurse specialists within the team that treats cancers that are attached to your specialist team, and that kind of act as a coordinator for your personal care. They are your first point of contact that you can contact when you have questions. When you have your first conversation, you take in a lot of news. Usually you'll have a loved one with you who might be just as similarly shocked. And 2 or 3 days later, a lot of questions pop up. that is where the cancer nurse specialists come into play, and where you do have someone that you should be able to contact easily to again ask for more questions, who navigates your care and who stays in close contact with you, navigating you through the different steps of your procedure. Knowing that that exists, I would really re-emphasize utilizing that and knowing that you have that someone and that there is someone that takes away a bit of that burden for you, and that you are not just left at home to your own devices. So the treatable colorectal cancers, the mainstay of colorectal cancer is surgery. That's a big staple of the treatment. Depending on if you've got a cancer of the colon or the rectum, you will either go very often for an operation first and then possibly some chemo or radiotherapy afterwards. While for the rectal cancers, it very frequently happens that you first have to undergo chemo radiotherapy to downstage the tumor, to then go for an operation. So the type of operation you're getting depends on several factors. One of them is the location of your tumor, but in principle, wherever your tumor is, the part that shares the same blood supply will be taken out, and the part in front of it and after it will be joined up. Depending on where the tumor is, that is a possibility or not to be joined up. So for most of the cancers, you will get a joint. For some of the cancers, you will get a joint, meaning that everything is joined back up and you on the outside shouldn't notice much. But the joint is thought to be a risk to not be watertight and to possibly leak. And that is when sometimes you have to get a temporary stoma. So a stoma bag, which means that a bit of the bowel is brought out to the abdominal wall and that you lose your stool from there and you get taught and trained on how to use that. That stays in place to get you through any other treatments that you need and any other time. And then when you make a recovery after a while, usually several months to a year down the line, the stoma can then be undone, where you then become to a point again where on the exterior, by having another operation, that on the exterior, you can't notice anything anymore. But in some cases, the cancer is in a spot, or you have other previous surgeries or any other health issues, etc., that limit making a joint. And then you might end up with a stoma for the rest of your life. So meaning that you have a stoma bag, a bowel that is attached to the wall, and then that you use that as a way to lose the defecation. This is usually something that people find incredibly scary and incredibly stigmatizing. But actually, once people have gone through it, all the research shows that people after a year down the line usually report a similar quality to life as general population again. So it can be very disheartening and scary, but with right support and right training and right equipment, you can get to a quality of life that is excellent. And you can get to a point where it does not limit your activities, and people do all kinds of things, including swimming and Olympic exercises along with this. The type of operation, along with the anatomical site and which bit of your bowel is being taken, also depends on what technique can be used to operate on you. So in general, in the UK system, we've got 3 different types of operations available. An old-fashioned open procedure, meaning that it's a big cut, usually down the middle of the tummy, and that the surgery gets performed through there. A keyhole operation, which involves pushing multiple ports, and I will show you pictures, multiple ports through the abdominal wall, which makes the scars much smaller because you get several between 4 and 7 small cuts on the tummy, and that allow instruments to be put through. For most of the operation to happen that way, And then eventually the bit of bowel that needs to come out will be taken out through a much smaller incision than you would have had if you had an open surgery. And the robot is an advanced keyhole operation where robotic arms get attached to the instruments, and it allows the surgeon to operate from a distance. It is not like the name would suggest that you are being operated on by a robot. You're still being operated on by a surgeon. It's just that the mechanics of it are slightly different. So here in this slide on the left hand, you will see the traditional keyhole operation. You can see the surgeon on the right side of that patient holding a camera, and they are both looking at a screen, and that screen is then showing them what that camera sees on the inside. And you can see that the surgeon on the right appears to be holding 2 instruments in his hands, and that he's using that to do the operation. On the right side of picture, you can see that there is a very bulky, heavy machine that has multiple arms sticking out, and those arms are attached to instruments that are inserted in a similar way as to the keyhole operation. And these arms then have a full range of motion that are controlled by joysticks that got operated by the surgeon, who is on this picture sitting in front and a few meters in front of the patient on the console, and in that way is controlling the movement of the instruments and the arms inside the patient. The advantage of these types of operations is that you have much less scars, much less post-operative pain, and that the recovery can be relatively faster, and that they reduce certain complications. So when possible, people nowadays will always see laparoscopic surgery as the default option, but there are still reasons to go for an open operation, and sometimes it's not technically feasible to do it keyhole, and your doctors will have chats to you beforehand about which operation type they will try to start off with. And also starting off keyhole does not necessarily mean that the operation will be able to finish keyhole. Keyhole sometimes can be very difficult, or there can be other factors during the operation that mean that you have to go for an open operation during the procedure and change the approach. So after these operations, there is a lot to take in and go through. Some people end up with stomas, and stomas, you need to learn how to manage those and to manage the equipment. And there are stoma nurses who will train you while you're in hospital, and usually you will not be discharged unless you are able to manage the basics of your stoma yourself. If you are someone who's taught to not be able to manage their stoma beforehand, they'll have discussions about if someone else, your carers or your relatives, are being taught or not. After the operation, depending on the stage that the tumor turns out to be and the type of tumor you've got, you might end up going for chemoradiotherapy, which can take up to several months. And then there's the psychological recovery and the physical recovery. Obviously, the scare of having had a cancer, even if the surgery sometimes is completed the treatment, for many people, surgery alone is the treatment, and they do not need chemoradiotherapy or anything else before or after, but they do have to be followed up for 5 years, meaning that they have to go to hospital and get examinations and scans and endoscopies, which can be a relatively stressful period. The recovering from an operation, getting back to your general fitness, but also the physical side effects that these operations can leave you with. Either that be your fitness, but also some of these operations can cause things that we normally tend to not discuss in our communities. For example, pelvic surgery can leave some people with sexual dysfunction, or in general, surgeries can have side effects. For example, you can later on in life develop hernias and abdominal wall deformities because of the scars. So this is again where you do not have to go through the struggle alone, and where there are lots of facilities available that tend to be underused in our communities. For example, going through the cancer diagnosis, going through surgery, and then having to go for chemo, radiotherapy, etc., for weeks to months on ends, can mean something's financially devastating, especially for people who are self-employed. For example, someone who's doing freelance work, or someone who's a shop holder, or but it can have catastrophic effects on them and their families. There are resources that actually help you with where you're entitled to have things like a financial advisor. There are grants available for hardship, etc., which again do get much underutilized by families. So I would love for you to have some chats to your own friends and your own network about things such as Macmillan. Macmillan is not just about having a cup of tea all together, or the things that that we normally tend to associate it with, but they offer some really practical support, and they can offer ways to navigate things. It would be fantastic if our own communities had support groups, because support groups do a lot of things for each other. It's not just about the emotional support that you're getting, but again, the sharing of practicalities, people who are further in the process than you are, but also talking about how to get second opinions, who's doing what treatments, what surgeon or what oncologist they've had a great experience with, and kind of getting insider tips. Another thing that most people are not aware of is that most GP centres will either have or have a link to a social prescriber who can navigate, again, a lot of the issues that can occur along with navigating a cancer diagnosis. And for those who are diagnosed with an incurable or terminal illness, the uptake of palliative care, symptom control, and hospice at home tends to be much less in the ethnic minority communities, which means that a lot of the burden falls on family, which obviously culturally, there is a culture of looking after your family, which is amazing. But you can see if you can navigate ways of accessing this kind of help where it takes some of the burden away, and you can still do the care and coordinate, but it means that you have much more resources and things to support you with it. And along with doing the practical care, they also offer a lot of symptom control, pain management, and all in all, a much more comfortable experience for the patient, who then has much less physical and mental suffering. So as a last thing, I want to point you out to these different websites that offer links and support to people who are navigating cancer diagnoses. But I also want to point you to the cancerresearchuk.org site that, in very simple layman terms, has oversight of all different cancers, their symptoms, their staging, the treatment options you can expect, etc., etc., which again gives you a bit of holding on to when you're advocating for yourself or your loved ones and navigating these conversations, to see what the normal guidance and the normal standard of things and what would trigger referrals are. So thank you very much for your attention, and I look forward to hearing your questions. Many thanks.
Excellent, excellent. Thank you very, very much, Miss Marwa Jama. Fantastic whiz through. I mean, this is it's timely. It's a timely subject matter. You've told us what colorectal cancer is, and it's interesting to know that it's the third most common cancer in Black people in the United Kingdom. It's also important to know that generally in population, if 20 of us are in a room, one person may likely have it in their lifetime. And sadly, the symptoms can be very vague. And it can also be symptoms of everyday things that happen. So if you think about having that long-term heartburn or a change in your poo habit, and you are an older generation person, you have had similar things in your family, your diet has not been the best one, you smoke, you are a bit on the big side, alcohol, you've had radiation treatment before, these are things that could increase the risk of one having bowel cancer. And I just thought about something while you were speaking. Look in that bowl, that toilet bowl, before you flush. Stop, look before you flush, because that may just save one's life. Know how your poo looks usually, so that if you know the normal, then you know when there's a problem. You've never had blood in poo, and all of a sudden you are having blood in poo. Speak up, please. Do not be silent. In our own social cultural fabric, sadly, we don't like to talk about things that, I always say, things that are below the neck. We just want to stop at the face, you know. Well, there are things happening in the nether regions. That blood in poo may not be just piles. That blood in poo may be the first thing that you will notice. And thankfully, for those of us in the United Kingdom, there is that test, that fleet test. Don't just throw it away once it comes through the post door. Don't look at that envelope and say, oh no, I'm not going to go and touch my poo. For goodness sake, it's your poo. It's not mine. Touch it. Take a little sample. These days, it's even easier. Before, you had to scoop a big size. Now, you just put like a mascara brush. It's really easier now, and you just take a sample and send it off. And I think we just need to engage as Black people. We need to use the resources before us. So well done, Ms. Jama. I just feel that stories that touch, like one I had recently, where a very close family friend went to the GP, kept going, just didn't feel well, was always feeling bloated, started feeling full easily, was having pain, kept going to the GP, and, you know, after a while, just felt, oh, they're not listening to me, stopped for a while. Then it was unbearable and started going again. And lo and behold, was found to have late stage of colorectal cancer. Let's be vigilant. Let's seek for help. Well done. Let's take the questions now. Very, very grand topic. Honestly, I learned so much myself, so much. Thank you so, so much. Ruth, do we have things in the chat? Because I could just pick them up myself. I saw one floating about.
Yes, we do. I've just messaged one to you actually directly.
Okay. Just a second, let's see. And is that a direct Zoom message?
Yes, I received that directly.
For some reason, I'm not able to access. Can you
Would you like me to read it out?
on WhatsApp, or read it out if it's directly, because I can't see the chat for some strange reason.
Yeah, no worries. I'll read it out. So this one is from the name. Okay, this one's from Barbara. Oh, it's now in the main chat, I believe. But Barbara asked, "Hi, Marwa, thank you for your clear and excellent delivery. Test stop age 73."
That's actually a great question. And it also reminds me that I should have said something else along with that. So the age test stops at 73 because on balance, and it sounds very harsh, but the survival benefits you get from screening the whole population who are older to catch a few cancers in patients that might not be fit or that are too frail to get surgery, it just then doesn't become cost effective anymore. But it is not unavailable. It is just not automatically available. So it means that from the age of up to the age of 73, you will be getting it every 2 years to the post. But there is, if you ask for it, you can still, over the age of 75, every 2 years, still do the test if you want to. It is just that it becomes on your demand, but you can ask for it.
Excellent. And I think that is one place where we fall short. And Ms. Jama mentioned it when she was speaking. When we need to ask, we actually need to go to the GP and say, I have been coming here for 3 months now. I am not feeling better. I think you should be referring me to the bigger hospital. Or you actually go and you say, I want to ask you, why am I having blood in pool? Do you think we should do something? You can ask in nice ways. Or you say, oh, I'm 73, but my father had bowel cancer, or my mother had bowel cancer, or I am now having change in bowel habit. I think we need to do something a bit more about this. So we should ask, we should speak out. I mean, culturally, we are often very, oh yes, we shouldn't query authority. We should take the information as it is. They are the professional. We're very respectful, but please ask, save your own life. I can see a chat here from Corinne to everyone. It says, hello, is there any information about entitlements or financial help or benefits that clients are eligible for, and any documents that hospitals and doctors can provide to support these applications or any applicants? Thank you.
So Macmillan offers financial advisors that you can access when you have a cancer diagnosis, and they can take you through these things. Obviously, as a medic, we don't have much more in-depth detail, but they do. So if you go to the Macmillan website and look up the finance section, I can't remember exactly what it's called, but or if you just Google financial advice in Macmillan, you'll be able to find some contact details, and then they usually can advise you specifically on your or your client's situation. And they can also help navigate things like benefits, people who've got a terminal illness and who can't return to work, how to navigate all the applications, etc. So there are financial advisors who can help with all this. And there are even some grants for people who are truly in financial difficulties.
Excellent. Thank you, Dr. Marwa. I want to say you have a lot of commendations in the chats. Now I can see my charts. Iyabo Fashion says, thank you, doctor, for that comprehensive exposition through research. And then Caroline is saying, this presentation is one of the best we've had. You were clear, practiced, and knowledgeable. Thank you. And then Pamela says, she's asking, does a bowel test kit come through the door at a certain age? No, sorry. Also, a bowel test kit comes through the door at a certain age. We are more likely to get it earlier. So why do we all get the kit after 50? I don't quite get.
I'm not fully sure what is meant by that question, but colorectal cancer is the age of it's a disease of age, so the incidence goes up when you get older. So 50 is kind of where you start seeing more and more. So that's the reason why they've put the screening there. But the screening is being pushed now. It used to be 60 and it's being pushed down to 54. And there's even some talks about pushing it down to 50. So there is recognition of it doing earlier and earlier. Much younger than that, the incidence is very low.
Excellent. And Joy Donaldson is saying that she wants to thank you, that you were incredibly informative in your presentation and it was very clear. Sadly, her mother died of colon cancer, and I am under the impression that this disease is hereditary. What do you have to say about that, Dr. Marwa?
So my condolences. I'm sorry to hear about your mom. Colon cancer can be hereditary to different types of syndromes, but it doesn't necessarily have to be. So having one family member being diagnosed usually is not necessarily seen as much of a risk, especially if they were diagnosed at a later age. There are, however, triggers to get further investigations if you have cancers coming along in your family in multiple people from the same side at a much younger age. So if you feel like, oh, my brother had cancer, my mom had cancer, my nieces had cancer, and it's all happening at a young age, etc. And it doesn't even have to be the same cancers. It can be different types sometimes that are linked to one syndrome. It is something that can require investigation. So I would again say that if you are worried about that, these are chats that you can have with your GP, who are then on occasions can even send you on to your geneticist. And more commonly, what will happen is if you, for example, or a family member gets diagnosed and you discuss with your specialist, and then actually within the family, I'm the fourth or fifth person within my sisters and brothers to get diagnosed, they will sometimes already trigger a referral for you to get the genetic testing. And if you then have the gene, that then triggers genetic testing for your other family members, which is really good in some sense, because that then allows people to get screened early or to even take some precautionary measures. So definitely, if this is a concern you have, vocalize it, because there are things that can be done on it and about it.
Excellent. Thank you very much. And thank you, Joy, for sharing that very touching personal information. Marva Rollins, thank you. You're saying thanks very much. I have certainly learned a lot and made notes to share with my friends and family. I have made use of the bowel testing kits. They come through the post and they are easy and painless. Thank you for putting that out there. Yes, people need to know that they are easy and they are painless and you get your result. For your information or action, Zana has said, can webinar attendees start receiving presentation slides going forward, or maybe certificates of attendance, if not the slides? I think Ruth will tackle that question, but very, very good suggestion. Thank you, Zana. Corinne, again, to everyone.
In the chat.
Sorry?
I've actually responded to Zana's question in the chat. But...
Excellent, excellent. Corinne, again, to everyone. Oh, yes, I see your response now. It's come up for me now. Hello, Zana. This is not an accredited course, so we do not give out certificates. As for the slides, these are the intellectual properties of the presenting doctors, so we do not make them available. However, you can catch up on sessions by heading to our YouTube channel and catching up on Facebook and LinkedIn. Yes, and they are actually shared there. Thank you for that response, Ruth. Corinne, again, to everyone. One thing we can all do, and that all is in capital letters, is monitor your waist size for weight loss and weight increase, as it can be a good early indicator. Do you want to speak to that, Dr. Jama? Because sometimes weight loss can be the last thing, actually, from what I know. Do you want to talk about, but I'm not saying you shouldn't check, but saying is an early indicator, maybe a bit. Dr. Jama, please.
No, you are right. It's a late stage symptom, because weight loss often happens because you've got advanced cancer taking up your energy resources. So no, weight loss is a relatively late symptom, but it is something to be alarmed by. But the thing that you could do, which is a much more earlier symptom, is the altered bowel patterns and the bleeding. And that's why you, like you, Dr. Loretta, have already said, look back at your stool. That is a much more easy thing to monitor. Obviously, I'm not discouraging you from looking at your weight. It's always good for many other health reasons, but it is not an early indicator of colon cancer.
Excellent. Thank you for that. We need to really buttress that as well. Roy Edwards is saying, thank you for your excellent presentation. Are there any preventative activities an individual can take or make to minimize the chance of getting bowel cancer?
Thank you. So yes, like discussed in the presentation, there are some dietary risk factors, such as red meat and processed meats, which now the recommendation is to try to minimize that to maximum 2 times a week. Having a good fiber-rich diet, which includes things like peas, lentils, pulses, dark fruits, berries, oats, etc. If you just Google fiber-rich, you'll be able to find a lot of resources. Smoking and alcohol is associated in a small amount with colorectal cancer. So stop smoking and using alcohol very responsibly, or even not, is wise. Then there are certain things that are falsely associated with colorectal cancer. So there are myths about things like sugars or aspartame, which you can find in light variants of drinks. All that has not been evidenced. So again, going out to the cancer research websites will tell you the modifiable risk factors that are proven by evidence and which ones are not. But in general, following a healthy lifestyle can prevent much more than just colorectal cancer.
Thank you very much. Taslim Ahmad is commending you. Thank you for a very clear and concise and informative presentation. Pamela is asking, is there religious appropriate support services available once people are diagnosed? As Black people, we often need guidance around this.
So once people have had bad news?
Yes, what she's asking is, are there religiously appropriate supportive services available once people have been diagnosed? So once they've had a diagnosis of colorectal cancer, are there places where you can point people to that are religiously or culturally appropriate services? Because as Black people, Pamela is saying, we will often need to be guided around or pointed in the right direction with respect to this.
So not through the generic NHS, but there is the Black in Cancer group, which I have linked in the penultimate page of my presentation, which is a relatively new group, I think based in London, who offer support and guidance to Black people who are living with cancer or who've got loved ones with cancer. So I think that's an excellent resource to start with if you want culturally and ethnically appropriate or sensitive guidance. When it comes to religion, I think that also mostly has to come from your own local religious leaders. I think a lot of mosques and churches, etc., would be very good to deliver one-to-one support. But when it comes to group support, I think there is also a lot of empty space in the community that needs to be developed. And I think one of the key things I hope we will do over the coming years as a community is start developing support groups, networks, and more open communication on how to navigate these diagnoses and how to live with them.
Fantastic. And sometimes it's worth coming to these kind of events by CAN to get information that could actually add value to some of the direction we go when, unfortunately, these kind of things occur. Thank you very much. Dr. Francis Wosu is saying, thank you for your information and your presentation. Barbara Simpson is saying, thank you for answering her question. And Joy Donaldson says, thank you, doctors, for your answers. Pastor Chinyere Sam Okorenta is saying, please let's all get involved with our future health research. It can help you know your risk. And Julie is saying to everyone, thank you for the session. ICWC Sheffield is saying, thanks, Dr. Marwa, for the excellent delivery. Are there preventable lifestyles we need to be aware of alongside the screening? I think you've harped on that, Dr. Marwa, Jama, but they say repetition is the hallmark of learning. Do you want to say a thing about that again?
Yeah, so
lifestyle.
I'll keep it brief. So lifestyle, diet is important, where red meat and very processed meats are damaging, so limit those to twice a week max. Have a good fiber-rich diet, which includes things like pulses, peas, dark vegetables, etc. Smoking, alcohol are also risk factors, so avoiding those is very wise. Obesity is linked, so keeping a healthy weight and keeping a good fitness is very good. And yeah, those are the preventable things.
Yeah, excellent. And when we do exercise, when we move, it helps our bowel motion as well. When you move, they actually respond to all of that movement rather than being just sedentary. So look for that habit, that exercise that you can do, that little change you can make. And of course, look in the toilet bowl before you flush. I think that's a very good lifestyle habit I have picked up from today's presentation. Juliana is asking us, some of the elderly find internal examinations very painful. I suppose she's talking about a rectal examination. Is there any way to reduce their pain or help them during this kind of examination, Dr. Marwa?
I think unfortunately they can be quite uncomfortable. I think a lot of it is also just the preparation, knowing what to expect, being talked through the examination, having someone with you who can hold your hand. Sometimes it can help to use a little bit of numbing gel on the finger, but there's not much effect of that. So yeah, I'm afraid that unfortunately they can be quite uncomfortable, but they are a very necessary test to do.
Okay.
Worst case, if people, the one thing I could maybe advise is if you already know that you're going to have it and you're a bit afraid, maybe take 2 paracetamols before going to the doctors. Maybe that will help, and ask them to talk you through things that you can be as relaxed as possible, be put into a nice, comfortable position so that you can tolerate things better.
Yes, and there's no harm in actually saying to the doctor, please be kind and gentle. There is no harm in saying that, because sometimes people are rushing and they just, but just say it. Let's voice these things. Let's not keep them in our hearts or in our minds, and let's make our own experiences a bit more pleasant, with better quality. Ruth is telling us that we don't have so much time left. Are there any questions anybody wants to ask us? Any hands up? We could take just one hand up and then round up. Anything at all? If none, I will be handing over to Ruth Akinradewo to round up the formalities for today's health hour. But honestly, Miss Marwa Jama, I want to say a big thank you to you for today. And I want to thank all the people who have attended today from wherever they've joined us from. Tell somebody to tell somebody. This 1 hour every Saturday could save our lives. Share the links, and once they are out, the recording, please share them. Well done to Khan, Katip, and all the team. Thank you very much, everyone. Ruth, you've got the floor. You are muted, dear.
Sorry, I thought I'd unmuted myself there. Thank you, Dr. Loretta. Yes, thank you so much, Dr. Loretta and Dr. Marwa, for a brilliant session. Really incredibly informative. And yeah, to think that bowel cancer is the 3rd most common cancer amongst the Black population definitely means know more about it and how to protect ourselves. So thank you so much again for that. Okay, hopefully you will be able to see my screen in a few seconds. So I could just have a confirmation once I'm sharing, that would be great. Okay, can you see my screen? Does everybody see a presentation? Yeah.
Yeah.
Dr. Loretta, fantastic. Thank you. Just needed someone to confirm. Thank you so much. Okay. Brilliant. So we're looking ahead to next week now. Sorry, this is being a bit slow. I don't know if you guys can see the presentation,
Loading
because
on
for
my
me it's just
end.
gone black. Has it gone black for everyone else?
Yes, it's gone black. There it is
Wait,
now.
try again. Okay, I think I'll have to leave it off slideshow because it's in a mood with me for some reason. Okay, so yeah, just looking ahead to next week's session, we will be at Healthy Aging for our next Health Hour session on Saturday, the 17th of August. And we'll be taken through that by Dr. Oluyemisi Amanda, or she goes by Dr. Amanda Adigwe sometimes. So looking forward to that session. Please do sign up via a link I'll share in the chat shortly. And you'll get the link to join that from 11 a.m. next Saturday. And then on Tuesday, so the 13th of August, we have our session on diet and lifestyle, which also takes place every between 6:30 and 8 p.m. Also on Zoom, Facebook, LinkedIn, and YouTube, just as our health hour does. And this coming week, it'll be on dietary links to cataracts, the silent vision, and we'll be through that by Dr. Kieran, and Sylvia Ofobe will be our host. So it'll be a really good session. And of course, you get the chance to ask your questions as well, just as you do with Health Hour. So that's an interactive and informative session. Cataract is actually the world's leading cause of blindness. So it's great to learn more about these things so that we can take preventative measures to protect against health conditions like that. So that will be a great session. Please do join us for that as well. We have our Healthy Home at the end of August, on the 30th of August, which is a Friday. And it will be, let me just double check, that's a Friday. Sorry. Yeah, that's Friday. So it'll be taking place between 4 and 7 p.m. in Gorton. And this is kind of part of an initiative and program that we have going on to basically amplify the voices of tenants in the private rented sector. So if you live in Manchester especially, we'd really encourage you to come and be part of that. It's a great opportunity to find out more about how you can empower yourself as a tenant, and to have conversations with landlords as well, and people that are significant movers and shakers in this sector. So please do find out more about that by contacting our team, by emailing homesforhealth@carn.org.uk, or you can drop a message in this chat now if you'd like to find out more information, and we can get in touch with you directly. We also have our Victims' Voice recruitment taking place. If you're not familiar with our Victims' Voice initiative, that's an initiative that we are doing along Manchester City Council with survivors and victims of domestic abuse. And so this is an opportunity to, if you've domestic abuse, you've been touched by it in any way, it's an opportunity to be part of a conversation about improving services in the region of Manchester and empowering victims and survivors. So that's a brilliant thing to get involved in. We've been running that for a bit over a year now, and we've seen really tangible impacts in the Greater Manchester sector of domestic abuse. So please do get in touch with us if you're interested in being part of that. We're also looking ahead to our Black History Month civic launch, which we're very excited about. That takes place every year in Manchester Cathedral, and this year it's going to be on Wednesday, the 25th of September. It's a fantastic opportunity to engage with a lot of Black-led organisations, key influencers, key stakeholders in Manchester and beyond. So if you're interested in exhibiting your organisation or services, please do get in touch with us to book a stall. There's a link there that you can scan. So if you've got your phone right there, right here with you now, you just pick it up, and the phone should, if you've got a smartphone, that is, it should be able to pick up on the QR code and send you directly to the portal to register. So if you have any issues with that, please do drop a message in the chat before we end this call. We also have our Decipher partnership. So we're partnering with Decipher to find parents and guardians that are interested in making a difference to early genetic research. Again, you can scan the QR code if you'd like to find out more about that, or you can email samuel@carn.org.uk, find out more about that initiative and how you can get involved. Because as we know, often not involved in a lot of research and clinical trials. And so we end up in a position where patient and initiatives that can help us or are designed to help us, actually, we don't know enough about because they haven't been tested on people with our ethnic heritage. So getting involved in that is a great way of having a say and making a difference in the health sector. So we'd really encourage you to get involved in that if that speaks to you. Thank you so much for listening. Really are grateful that you've turned up to join this morning and afternoon, and we hope you have a wonderful rest of your day. Thank you so much again for listening, and get in touch with us if you have any questions beyond today's event. Thank you so much again to Dr. Marwa, and I will stop there. Thank you.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CARN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
All right, thank you everyone for joining. See you next week.